The anatomy of the eye, I taught you last time. Eye, retina, and the visual pathway. Today, I'm going to discuss mainly the visual pathway, the anatomy of the visual pathway. Last time I discussed eye and the retina, right? This is the eyeball. Just remind you anatomy. This is eyeball and the cornea up to the fovea. The media should be very clear. Transmit the light rays from the object to form a clear image on the fovea. Therefore, all the structures from here, cornea up to the fovea, should be very, very clear. And these are the structures: cornea, epicema, the light rays entering into the eye regulated by the pupil, which is formed by the iris, and the lens, the crystalline lens, is crystal clear unless there is any opacity such as that. And this is a vitreous body, and this is the fovea where you get the image fallen onto the very highly sensitive area of the retina at daylight. It consists of cones cells, and this is all the retinal ganglion cells forms axons, and it's just gathered here that at the starting point of the second cranial nerve you call optic disc, and it's gathered here. There's about 1.2 million of axons which just runs in this optic nerve. First, I discussed what are the common systemic diseases you should know affecting the eye. There are many, many diseases. Sometimes you can't just, there's in books, but I will just touch few common diseases that you are coming across in your practice. And therefore, as a first medical officer, if a patient comes to you, you should be able to identify this clinical signs may have underlying retinal or any ocular or orbital problem. But I can't discuss all because you will be coming to our appointment. While doing the appointment, you have to catch the other things which is in the ward also. So I can divide the common systemic diseases such as infectious and the non-infectious disease, right? Then the non-infectious disease, there may be a granulomatous and the non-granulomatous. The infectious disease, the common infectious diseases are toxoplasmosis, toxocariasis, tuberculosis, syphilis, leprosy, HIV, and cytomegalovirus infection. The non-infectious diseases are endocrine, diabetes. The commonest is diabetes and the thyroid disease. And other connective tissue disorders such as rheumatoid arthritis, SLE, vaginas, polyarthritis nodosa, and systemic sclerosis. And seronegative arthritis are vasculitis, giant cell arthritis, sarcoidosis, Behçet's disease, VKH, Vogt-Koyangi-Harada syndrome, and phakomatosis. I'll just touch few of them just to get familiarized with the clinical symptoms. The thyroid eye disease, you know, the thyroid eye disease, this is one of the most common disease which can affect the eye. Because it can be euthyroid, it can be hyperthyroid, it can be hypothyroid. Therefore, the systemic disease, there is a soft tissue involvement. There is a soft tissue involvement of the orbit, which most the common pathogenesis of thyroid eye disease. There may be a periorbital swelling, lid swelling, proptosis, chemosis, dry eyes, and the superior limbic keratitis. Because of the dry eyes, they get superior limbic keratitis. And the lid, there are special lid signs because of this thyroid ophthalmology. You get special lid signs. There's special lid signs, the lid retraction, lid lag. That means the lid may be drawn backward because the eye is protruding forward. And the lid lag is when the patient is looking down, the lid is not comes smoothly because the muscles are tensed up. There's a restrictive myopathy. The ocular muscles get infiltrated and it becomes a bit more tight and it's not act smoothly, and you get tight muscles which does not move with the normal eye globe. Therefore, it's a restrictive myopathy. And the compressive optic neuropathy, that's a because of the swelling of the orbital contents and the soft tissue, ultimately produce compression of the optic nerve which runs within the orbital cavity at the center. And because of the compression of the posterior part of the globe, you get choroidal fold because anterior part of the globe is protruding and exposed. There's no compression, but within the posterior part, within the orbital cavity, you get compression and you get choroidal folds. These are the clinical signs of thyroid eye. This is the acute phase. Actually, it's an inflammatory phase. Sometimes it may cause inflammation because it's an autoimmune condition. There's a chemosis, red eye, tearing, and enlarged blood vessels, and sometimes there's a swollen conjunctiva. The swollen conjunctiva we call chemosis. And because of this inflammation of the upper lid conjunctiva, also there's a red eye, and ultimately rubs on the cornea. With each blinking, you get superior limbic. Tear films are unstable. I told about the tear film last time. It is unstable. And you get superior limbic conjunctivitis. And this is the other signs. This is the bilateral proptosis. It may be symmetrical, it may be asymmetrical, or it may be unilateral. Any proptosis, any protrusion of the eye of a patient comes to you, you have to suspect the thyroid eye disease. That is the commonest cause of proptosis in a patient. Therefore, when the bilateral lid retractions are there, you get, though there's no proptosis, you get the staring look. You can see this upper limbus, the corneal upper border can be visible. Normally, the corneal upper border is closed by the upper lid. Usually, you can't see the circle of the limbus, that's the circle. You can't see the upper border, but in the when there is exophthalmos, there's a prominent eye, you can see proptosis and lid retraction. And this is the unilateral case. This size seems to be normal, but this size is proptosed and there's a lid retraction. And this, you can see when the patient looking down, the right eyelid is not coming down, but left eye is normally comes down with the down gaze movement. That is unilateral. This is a unilateral thyroid ophthalmopathy. This is also the asymmetrical unilateral thyroid ophthalmopathy. Then proptosis, the protrusion of the eye. It occurs in 50% of cases when there's a thyroid eye disease, mainly thyroid toxicosis. The proptosis we can measure from this angle, from this, you can feel the orbital rim here, and we can measure this distance up to the cornea. That's the amount of proptosis. Usually it stops here, right? But this eye, it has come just nearly to the orbital rim. But when you look through the orbital rim, superior, through the forehead, with the tilted head, you can see the cornea. Normally, you can't see the cornea on the plane of forehead. These are the choroidal folds because the compression of the posterior part of the globe ultimately forming a folds in the posterior retina. Then what are the treatments? Then I don't have to go through that. The treatment options are just conservative treatment if it's not severe. And if there's exposure keratitis or something, then you have to start the steroid, then the radiotherapy, and sometimes you may need surgical compression of the orbital wall to get the eye globe backwards. Otherwise, patient go blind because of this exposure keratitis. Other things are orbital. Because of the compression, you can see these are the on a CT scan. This is the eye globe, this is the lens, this is the retina, and starting the optic nerve here, right? You can see the optic nerve. In thyroid ophthalmology, you get swollen up. These muscles are get swollen like a fusiform enlargement. The tendons are sparing. That's a specific sign of CT scan of the orbit. And this is a fusiform enlargement of the extraocular muscles. It's a typical feature of thyroid ophthalmopathy, which can differentiate from other proptotic patients. And because there's an increased fat cells and the inflammatory cells, which cause compression of this optic nerve, end up with a compressive optic neuropathy. And you can just elicit a relative afferent pupillary defect by simple pen torch. And if there's any afferent pupillary defect, though the patient doesn't complain visual symptoms, you have to do something. Otherwise, patient go completely irreversible blindness because of the compressive optic neuropathy, which cannot be reversed. Therefore, you may need some surgical decompression of this orbital wall, the medial or inferior orbital wall, to just get the content released from the narrow orbital cavity. There's a restrictive myopathy. You know, there's when the eye is moving, this eye is not moving. Usually, the restrictive myopathy can happen with the vertical gaze and also the horizontal gaze. Can you see this? This eye is not moving. And though this eye is looking down, this this leg, right, it is behind, not like this one. And this eyeball also not moving much. And there's a medial rectus limitation. And here, this lateral rectus limitation. All the muscles can be affected asymmetrically. These are the restrictive myopathy, which does not move with their yoke muscle. Then we'll move on to the other topic, the uveitis. As I told you, there are several diseases which can affect the eye, infectious and non-infectious disease. Usually, they can affect the eye uveal tissue. The eye uveal tissue, I told you, there's the uveal tissue starts from the iris, ciliary body, the choroid. Those are the uvea of the eye, the black colored, highly vascularized tissue of the eye, which nourishes and supplies the blood to the eye, most of the avascular tissue. And therefore, any inflammation can cause the inflammation of this uveal tissue. And there are many systemic diseases, as I discussed you, maybe acute or chronic, produce uveitis. And uveitis is an inflammation of the uveal tissue. And this is usually symptoms. In acute disease, it's a red painful eye. There may be blurred vision. There may be floaters. There may be loss of vision in a severe case if it is involved the optic nerve or the retina or other systemic features. And the signs are circumcorneal injection, hazy cornea in the anterior chamber. There may be hypopyon. Hypopyon means there's a pus collection in the anterior chamber and it's a sediment down while the patient is upright position, or it's maybe some other side when the patient is lying down. There's a pus collection in the anterior chamber. There's a posterior synechiae. Because of the inflammation of the iris, usually when this inflammation is trying to adhere to the other structures which it has very near contact. And especially the lens has a contact at its pupil. Therefore, the pupil get attached to the anterior lens surface called posterior synechiae. When the iris gets attached to the cornea at the angle, at the most peripheral part of the cornea, that called anterior synechiae. The iris attached to the cornea at its periphery. The posterior synechiae means pupil is attached to the lens called posterior synechiae. Then it can develop cataract because when there's any metabolic insult or inflammatory insult in the anterior chamber, produce cataract. And in the posterior choroid, the ciliary body and the pars plana inflammation, you may produce vitritis. The inflammatory reaction caused within the vitreous body. And then later they may cause retinochoroiditis. The choroid get inflamed and it may spread into the retina. Those are the pathophysiology of uveitis. The common causes are inflammatory, the seronegative arthritis, giant cell arthritis, connective tissue disorders, sarcoidosis, and Behçet's disease. The systemic infections are common with immunocompromised patients, especially these are the toxoplasma can be immunocompetent for immunocompromised, but the CME, TB are common with immunosuppressed patients, and herpes zoster retinitis is common with immunocompromised, and the syphilis, leprosy, and candida. This is a patient with acute anterior uveitis. Can you see the pupil is irregular? It is not dilating. There are some tiny white deposit on the cornea, most inner part of the cornea that you call keratic precipitate. And this pupil attached to the cornea because it does not dilate. Can you see? This is attached. And there are some inflammatory, the cloudy appearance of the anterior chamber is not clear as the normal light. And there is a circumcorneal injection. It's a red eye, which is more confined to near the towards the cornea, and it fades off towards the periphery. That is how you just differentiate whether this intraocular inflammation is a redness is more towards the cornea and the limbus. If there's a conjunctivitis, the redness is more towards the periphery of the conjunctiva, towards the fornix, that's towards the lids. Can you see? I said there's a posterior syndicate, the attachment of the pupil, inflammatory attachment of the pupil onto the cornea. It's very difficult to release, and therefore you have to, at its acute stage, you have to put the dilating drops, the cyclopentolite to release this posterior syndicate. This is hypopian. This pus, can you see the lustreless cornea, the anterior chamber? It's not very clear. There's a collection of pus inside the eye. That's a hypopian. This is the acute retinal necrosis, especially in cytomegalovirus infection. And this is like a bushfire. It's described as a bushfire. And this is the TB. TB like the focal retinochoroiditis, focal patches of retinochoroid. There are many causes, but one cause is a tuberculosis. Those are the infections. And I come to you for with some common disease like a toxoplasmosis. This is the sarcoidosis. Sarcoidosis is a non-granulomatous, non-infectious inflammatory disorder, fairly common. But the lungs is the most common organ to be involved. Therefore, 95% of lung signs are there. Then thoracic lymph node enlargement in 50%. There's a skin nodules like this. There's in non-infectious granulomatous skin nodules in 30%, and eye involvement in 30%. Therefore, sarcoidosis, the ocular involvement, the anterior segment lesions 30%, and therefore these are the conjunctival granuloma, lacrimal glands enlargement and inflammation. It ultimately ends up with dry eyes, acute or chronic uveitis, keratic precipitates described as mutton fat, and because they are large and greasy, because it's like a mutton fat. The retinal posterior segment involvement are, can you see there's a vasculitis, the candle wax like this, there's an inflammation around the vessels like a candle wax dripping, and this is a venous occlusion, venous hemorrhages, there's a branch retinal vein occlusion, retinitis, and new vessels formation and infiltration. You don't have to remember all those things. You just remind the sarcoidosis can cause severe vasculitis and the retinitis. Those things are important because when you look at the eye, fundus with the ophthalmoscope, if any signs are present, you have to refer to an eye unit because it's a sight-threatening problem. Then the rheumatoid arthritis. All of you know the rheumatoid arthritis is one of the common diseases we are seeing day-to-day life, but it can also have many eye problems because it's a chronic inflammatory disease of the body. Scleritis is an inflammation of the sclera. The scleral tissue ultimately gets severe painful red eye. It may be a focal, it may be sectoral, or it may be diffuse all around of the sclera. Then it can also divide non-necrotizing and the necrotizing. Sometimes because of this inflammation, the sclera becomes dissolved. Dissolved means it becomes thinner and thinner and thinner, and you can see the exposing underlying choroid tissue. Therefore, this is very, very dangerous because there's a very thin sclera around that, and the globe shape also altered, and their vision also get decreased. Then posterior scleritis, you can't see clinically, but when you look at through the pupil at the fundus, you can see the signs of posterior scleritis. I'm not going into detail, but just remind it can happen in the posterior part of the globe also. Then it can affect the cornea because of the dry eye or due to limbal infiltration. It's a marginal corneal ulceration. These are the corneal involvement. This may be a chronic and asymptomatic circumferential thinning of the limbus, and this is the severe inflammatory marginal ulceration, which is common in scleritis. Is a very acute and painful circumferential ulceration. It's a very side-threatening, and it can cause infection, and you may lose the eye and you may lose the vision. This also can produce severe refractive changes. Then we'll move on to the phakomatosis. Have you heard about phakomatosis? It's a disease actually without any inflammation. The neurofibromatosis in pathophysiology in the neural tissue. There's a neurofibromatosis of the, what are the eye signs in phakomatosis? There are many kinds. There's 3 types mainly: neurofibromatosis, Sturge-Weber syndrome, and I'll go to that. This neurofibromatosis. We can divide into the plexiform neurofibroma. That is commonly just affect the eye. This anterior part of the eye, especially the lid. Therefore, the plexiform neurofibroma is diffuse enlargement of nerve fibers and cause foggy, just enlarging and thickening of the skin. And if it is affected on the upper eyelid, it can just hanging over the eye and reduce vision because of the ptosis. And anterior segment, there may be lesion nodules and prominent corneal nerves. And then it can affect the glaucoma and choroidal hematoma and the cataract. The neurofibromatosis, orbital involvement, it may have a risk of optic nerve glioma and sphenoorbital encephalocele. This is the eyelid neurofibroma type 1, the plexiform neurofibromatosis. You can see this is a diffuse enlargement and hanging skin of the eye. These are the eye signs. This you may not see with the naked eye. This has to be examined on the slit lamp. There's a lesion nodules, but it can appear in your MCQ. And this is a congenital ectropion, and there's a hematoma and maybe pigmented hematomas inside the retina. They can develop cataract without any, not age-related. This is a presenile cataract can happen because of the neurofibromatosis, and there may be other hematomas, and the pigmented or unpigmented hematomas can be seen in the retina. And optic nerve glioma, you can see it can affect the optic nerve glioma invading the hypothalamus. It's spread onto the hypothalamic area because while it travels through the chiasm. Sturge-Weber syndrome. The Sturge-Weber syndrome is the other type of phakomatosis. There are many ocular features. The episcleral features, the episcleral hemangioma, choroidal hemangioma, glaucoma, and the nevus flammeus. These are the Sturge-Weber syndrome signs. Therefore, the systemic features are there may be a nevus flammeus. This is a capillary hemangioma of the skin, and it may affect that ipsilateral eye. Usually, it's a unilateral. One side of the face is affected, and it also produces peripheral intracerebral hemangiomas. And this is common with type of parietal lobe epilepsy. They can present with epilepsy because of this hemangiomas in parietal lobe. They are usually mentally retarded and they may cause hemiparesis too. And these are the signs. These are the episcleral venous dilatation. These are the choroidal hemangiomas in Sturge-Weber syndrome. Then the other phacomatous is tuberous sclerosis. Tuberous sclerosis is a mentally handicapped epilepsy and adenoma sebacum. So all these syndromes you can see in your while doing the neurology appointment or your medical appointment. There may be skin lesions or ocular lesions. The adenoma sebacum, ashy spots, scapulae spots, chagrin patches, and the skin tags. Those are the skin signs. These are, I also can remember still while I am doing the my neurology appointment, I have seen these things. And also the ocular lesions, the retinal astrocytoma, hypopigmented iris spots, and the visceral hematoma. These are not common with our ward, but these are very common with medical ward or neurological ward. You can see these are the adenoma sebacum, the ash leaf spots, and the chagrin patches. That means there's a thickening of the focal, thickening of the skin, this distributed along the nerve fibers, the nerve fibers under the skin. These are the hematomas, the visceral hematoma, and this is a subungual hematoma. Right? It can affect the kidneys, it can affect the brains, and it can affect the posterior cerebellum. And retinal astrocytoma in the tuberous sclerosis. If you suspect any patients, you have to refer to us. It can cause retinal astrocytoma, especially in tuberous sclerosis, and it's a typical mulberry-like tumor. This we can just do some less treatment around that. This herpes zoster ophthalmicus is one of the common disease entity which we are seeing day-to-day life, and it's the herpes zoster ophthalmicus means it's in all the ophthalmic branch of the trigeminal nerve. It can affect any branch of the nerve in our nervous system, but if it is affect the ophthalmic branch of the trigeminal nerve, we call herpes zoster ophthalmicus. This ultimately, if it is affects this nasociliary branch. Nasociliary branch is at the tip of the nose. It supplies along the lateral side and will as the tip of the nose. That is the nasociliary branch involvement. That means the intraocular complications are very high. If you see these signs, you have to refer those patients to eye ward because we have to follow them up for a long time because there are many complications of the eye with this herpes zoster ophthalmicus. And these are the acute stage. There are lid ulcers, scarring, and trichiasis, and there may be keratoconjunctivitis because of the direct involvement infection of the cornea. There may produce corneal ulcers, stromal keratitis, scleritis, inflammation of the eye, uvea, glaucoma, and retinochoroiditis. These are the chronic, dendritic type of ulcers involving the cornea due to herpes. And can you see there's a scarring of the lid? The lids are scarring, there's no eyelashes, therefore not producing the tear film nicely. As I told you, if these megalobin glands are non-functioning, you have dry eyes. Because dry eyes, there may be ulceration of the cornea. It's a very dangerous and patient go blind. Infection of this ulcer ultimately end up with severe vision-threatening complications. Therefore, you have to treat them very carefully and follow them up for a long period if you have involvement of these eyelids as well as the nasociliary branch. This is the retinitis, acute retinal necrosis, and you may have extraocular nerve palsies because it is involvement of the orbit. Then I have many cases in my ward because this asymmetrical involvement and different branches of the extraocular nerve involvement may produce extraocular nerve palsies. And tuberculosis, though the common disease entity, but the eye signs are usually less. But if any patients comes with uveitis, unexplainable bilateral uveitis, we have to suspect sarcoidosis, we have to suspect tuberculosis, because those are one of our very common disease which can infect the human. It can present as anterior uveitis like this. It can present as choroiditis like this, and it can present as vasculitis because of vessels involvement, and also it can affect the nerve head, papillitis, inflammation of the optic nerve head, and miliary tuberculosis of the retina. Then other common disease is a toxoplasma of the eye. Then when this toxoplasma is a parasitic disease, it can cause congenital toxoplasmosis. It can cause the acute toxoplasmosis. It's transmitted by a cat, and usually when the congenital toxoplasmosis is there, usually there's no active infection. The child, when the child gets then the child age is growing, and then you may see the patient, the child can't see because the toxoplasma choroiditis has involved the foveal area, and there's a damage to those areas unless because of that patient lose vision. Usually it's common with the immunocompromised patient. It can reactivate after some stage of our life. Therefore, you have to check the immunocompromised, because especially HIV/AIDS, it can get reactivated. And the long-term maintenance, you have to give the long-term maintenance doses to prevent relapses. This is the commonest feature. This is old toxoplasmosis scar, and it gets reactivated. This black scar is a punch-out scar is there, but when it's reactivated, it's like a headlight in the fog. There's a vitreous cells in front of the inflammatory lesion, and you can't see the lesion properly. It's a headlight in the fog. This is also same. This in immunocompromised patient, they may get severe reaction, and you can see there are some vasculitis. And diabetic eye disease, other common disease, it can cause presenile cataract, glaucoma, and the diabetic retinopathy. These are the main complications of diabetes. Diabetic retinopathy is most dangerous binding complication. It is the most common cause of blindness in working age group. No cure other than prevention and control. Diabetic ocular complication, as you know, it may be a cataract, but it is just beyond the senile cataract, but you can have cataract if the patient has uncontrolled diabetic mellitus. Therefore, this is a very wide measure cataract can happen at any age, even in childhood if the patient has type 1 cataract. Then the patient are high risk for glaucoma, and also the patient can have diabetic retinopathy. Can you see? When you have diabetic retinopathy, there may be a focal leaking of the blood vessels and exudates and loss of retinal edema. You can't see some areas of your visual field. And the retinal vascular occlusion, central retinal vein occlusion, can happen with a high risk for diabetic patients as well as hypertension. And then there's the neurological palsies, the third nerve palsies, fourth nerve and sixth nerve. All nerve palsies are common with diabetic retinopathy, diabetic disease, and also the eyes are very high risk for endophthalmitis, especially if after surgery. Therefore, if you are going to do any surgery of the eye as well as in the other surgical procedures in the body, they are very high prone to get infection, because if you get infection in the eye, not like in other surgeries, it's very difficult to cure and patient may completely go blind. These are the different stages of diabetic retinopathy. Just you can get familiar with few stages, right? This is the normal eye. Can you see this is the optic nerve head? And these are the vessels which emerge through the optic nerve head and this passes, and this is the fovea centralis, which is the most sensitive part. It is avascular, and this because of this lack of ganglion cells, only the photoreceptors, and then you can see the normal retina. This is the area of macula. And these are the early diabetic changes. You can see there are some microaneurysms with few hard exudates. There are focal leads which is involved in this area. This is more sensitive area. This is called diabetic maculopathy. And this is the extensive diabetic maculopathy, clinically significant macular edema. And as I show on the picture of the visual field, they can't see very well. Right? Ultimately, it may produce proliferative diabetic retinopathy. It may not be very clear, but it is, you can see there's a neovascularization. Ultimately, it may bleed into the retina and into the vitreous cavity. You can see there's a bleeding. The late stage is the fractional retinal detachment. This is the fractional detachment. This is the visual pathway, just starting from the eye, just this eye, the retina. This is the neuro-ophthalmology. You have to know the visual pathway anatomy very well. Because of the eye science, from the eye science, you can detect where is the lesion. Right? Then you can help as the ophthalmic physician, you can help the others if they come with eye science to detect where the lesion is, because it starts from the retina and it travels into the brain through the optic nerve and it forms the chiasm. And the chiasm, then from the chiasm, it's called the optic tract. Then the optic tract forms the geniculate body and it forms the optic radiation and ends up here with the calcarine sulcus and the visual cortex. These are the anatomy, basic anatomy. And how do you examine the second cranial? You have to check visual acuity. You have to check the color vision by red cap bottle, whether there's any desaturation of the color. And you have to check the visual fields and you have to check the pupils. These are the four main type of examination of the second cranial nerve. Then these are the reduced visual acuity, the afferent or efferent pupillary defect, visual field loss, dyschromatopsia means desaturation of the color, there's a reduced brightness sensitivity, reduced contrast sensitivity, and visual field defect. But if you just if you catch the reduced sensitivity, pupillary defect, color vision diminution, and the visual field defects, that's enough. Right? This is how it's affected. If there's any damage to the optic nerve level at the here, optic head or optic nerve at its starting point, and you can see this complete loss of vision. Or you can have, if there's some fibers of the retina will affect, you can have an arcuate visual field defect. This is common in glaucoma. This is the optic nerve has affected this common optic neuropathy. This is the macula or the optic nerve head papillitis. It causes centrocecal scotoma. Then if it is effect at the chiasm, you can get by temporal hemianopia because the nasal fibers are processed at the chiasm. If it affects the optic tract, it causes the homonymous hemianopia. If it is affects the optic radiation, also causes homonymous hemianopia. Therefore, what are the diseases you can get in the optic nerve? If any type of optic nerve insult, ultimately end up with optic atrophy. Optic atrophy is paired optic disc. It's a primary optic atrophy. Paired flat disc, clear margin, attenuated papillary bladderses. And the causes are traumatic optic neuropathy, retrobulbar neuritis, compression lesions, hereditary optic atrophy, or toxic or neuron. These are the common cause of primary optic atrophy. You can see a paired disc with very clear margin. Then the optic neuritis. Optic neuritis is a swollen inflammatory optic nerve head due to inflammation of the optic disc within the eye. Actually, eye, this starting point is retina and it's end up at the posterior eye globe. Then this retrobulbar optic neuritis, it's beyond the sclera. The optic nerve inflammation is beyond the sclera. Then the neuroretinitis is in the nerve fiber layer. Retrobulbar means from the optic nerve, from the sclera up to the optic chiasm. Papillitis means at the disc. And the neuroretinitis means there's the involvement of the nerve. The optic neuritis What are the etiology? It's a multiple sclerosis, one of the commonest cause of optic neuritis in young age. Then there may be infectious, as I told you, any of the disease, sarcoidosis, non-infectious granulomatosis disease, TB, and chronic inflammatory problems can cause para-infections. The infections are syphilis, herpes zoster, Lyme disease, many diseases you have to exclude any type of optic neuritis, and the non-infectious are these two. Therefore, the other things in the elderly age, if you get the optic neuritis, you have to divide into two, non-arthritic and the arthritic optic neuritis. The arthritic optic neuritis is usually associated with the inflammation of the artery due to giant cell arteritis. Non-arthritic optic neuritis is common with elderly and hypertension and diabetes because it's an occlusive disease with no inflammation. Therefore, common neuropathy in elderly with 50 to 70 years, occlusion of the post-ciliary arteries because of the atherosclerosis. And these are the high-risk disease, diabetes, hyperlipidosis, collagen vascular disease, hypotension, sleep apneas, and treatment with Viagra. The clinical presentations are painless sudden loss of vision, severe vision loss, optic neuritis, and pale disc edema, and treatment as other systemic ischemic disorders. This is the types of optic neuritis. This may be pale or hyperemic, and there may be end up with secondary optic atrophy with blood margin. Usually, the visual prognosis is not very good. This is the arthritic ischemic optic neuropathy, common with giant cell arteritis, the sudden profound loss of vision with pain and the signs of giant cell arteritis involvement. That you get temporal artery tenderness, jaw claudication, and thickening of the temporal artery, diminished pulsation of the temporal artery. You know the giant cell features of giant cell arteritis. Then you have to treat those patients immediately because there's a high risk of getting the other eye also if they have a giant cell arteritis. Their CRP and the ESR is very high. Therefore, they have to treat with IV methylprednisolone consecutive doses. The diabetic papillopathy is uncommon. As the other retinal complications, these are uncommon. Visual acuity 612 or better. It may be bilateral or there may be a distal endothelium. Differential diagnosis are Leber's hereditary optic atrophy, inherited mitochondrial DNA mutation, nutritional optic neuropathy. The toxic nutritional optic neuropathy may be tobacco, alcohol, vitamin B deficiency, or pernicious anemia. You have heard about vitamin B deficiency also can cause optic neuropathy. The papilledema, the most important clinical entity for you, because if you miss papilledema, the patient may die within few days because we have to detect with the ophthalmoscope any suspicious patients for papilledema. It's a bilateral swelling of the optic nerve head. It is bilateral disease, not the unilateral, due to raised intracranial pressure. With the normal intracranial pressures are less than 80. Children's less than 90 and adults 210. These are the normal intracranial pressure. The papilledema caused by congenital acquired obstruction, Sylvian duct obstruction, or space occupying lesion, meningitis, cerebral edema, pseudotumor cerebri, cerebral venous thrombosis, diffuse cerebral edema, severe systemic hypertension of CSF tumors. These are the optic papilledema. There's bilateral, very angry looking. There may be splinter hemorrhages, blood disc margin, venous engorgement, loss of venous pulsation, and there's later it causes champagne cork appearance and ultimately end up with secondary optic atrophy, very long-standing papilledema. Clinical features, headache, projectile vomiting, but all those patients, unless it's a secondary optic atrophy, the patient may have near normal vision. That's how you differentiate from the optic neuropathy. Headache with sinister features, projectile vomiting, deterioration of the loss of consciousness, sorry, visual amaurosis, reflex, horizontal diplopia, and the visual impairment in long-standing cases. We have heard about the false localizing sign. This means horizontal diplopia on and off because of the lateral rectus paresis due to raised intracranial pressure and stretching of the lateral sixth nerve while it traversing through the cranial process. And there are stages: the mild hyperemic disc, blood disc margin, and loss of cupping. Cup is become filled with edematous nerve fibers and loss of venous pulsation. Established slightly reduced vision may be, if it is established and it's late stage, vision may be about 6.9 or 6.12. Hyperemic elevated disc, champagne cork like, peripapillary frame shape hemorrhages, retinal folds, incomplete macular star. Especially macular star comes where there's a malignant hypertension, and also if you do a visual fields, you can get enlarged blind spot, because any optic nerve disease, we are bound to do a visual fields. As I told you, it's a part and parcel of second nerve examination. The causes of disc edema are bilateral. It's a papilledema is bilateral, accelerated hypertension bilateral, anti-optic neuropathy usually may be bilateral but asymmetrical, and pseudo edema in Leber's optic atrophy, methanol poisoning, and intraocular disease, central retinal vein occlusion, uveitis, scleritis, ocular hypertonic. Those are the unilateral cause of disc edema if there's any pathology. The pupillary examination. Pupillary abnormalities you have to detect at the bedside as a part and parcel of your neurological examination, the circumcranial nerve examination. Afferent pupillary defect, relative afferent pupillary defect by swinging flashlight reflex. You have to learn those examinations at the ward while we are doing the appointment. Efferent pupillary defects, anisocoria. Anisocoria means it's an asymmetrical pupil in each eye. Usually, we have a symmetrical body, but slight difference in the right and left. But this marked difference with significant difference that you call an isocoria. The clinical anatomy of the pupil pathway, you should know afferent, you should know efferent, and there are autonomic. These are the pupillary. This is the pupillary pathway. You can all the temporal retinal fibers passes, and there's a, like I said, the LGB, and it passes to the pretertal nucleus and then to the Edinger-Westphal nucleus, and different pathway to the through the ciliary ganglion into the eye pupillary muscles. The causes of the RAPD or APD is optic nerve insult. Any optic nerve insult cause this one: the optic neuropathy, optic atrophy, compressive lesion of the optic nerve, or any trauma, surgical trauma, or any direct trauma. Different pupillary defects due to any compressive third nerve compression. An intracranial hemorrhage may cause third nerve damage. Cavernous sinus thrombosis may cause superior branch of the third nerve damage, and surgical third nerve palsy. The autonomic denervation, the autonomic supply of the eye will denervate. Then we have heard about this Horner syndrome. The Horner syndrome is one of the sympathetic denervation of the eye. It can affect the eye. Eye is small, narrow, and this is mild ptosis, and Meo's pupil, reduced iris pigmentation due to reduced adenochrome deposits, and it can be classified as there are three different branches of the autonomic sympathetic nerve: the central, preganglionic, and postganglionic. You may get familiarized how do you just diagnose these things. There's a Aedis pupil is a denervation of the parasympathetic. It's a post-viral infection of the ciliary ganglion, ultimately cause the parasympathetic denervation. There's a denervate the sphincter pupillae, which is supplied by the parasympathetic, and it's a diminished tendon reflex. These are the signs of Horner's. Mild ptosis, Meo's pupil. It's a congenital Horner's. Mild ptosis, asymmetrical. And this pupilla is asymmetrical. This is Neo's pupil. This is the pathway. I'm not going into detail because you are the anatomist, no, not me. No. Then the Argyll-Robertson pupil is one type of pupillary abnormalities which can affect the dorsal midbrain syndrome. The absent light reflex, normal near reflex, and small irregular pupil. The causes are neurosyphilis, type 1 diabetes, myotonic dystrophy, Parinaud's and dorsal midbrain syndrome, and the encephalitis and chronic alcoholism. Just remember few for the dorsal midbrain syndrome. Any visual pathway lesions, the optic nerve damage from globe to chiasm cause total visual loss, afferent pupillary defects, and optic atrophy. The optic chiasmal damage does not cause pupillary signs, and this is commonly damaged with pituitary tumors, pinealomas, and may cause dorsal compression and also cavernous sinus disease and the carotid artery aneurysm. Therefore, any visual pathway, any lesions which traverse through the visual pathway end up with visual field defects. Therefore, looking at the type of the visual field defect, just get familiarized with this one. Type of the visual field defects, you may just take to where the lesion is. If the cortical, posterior cortical lesions may produce macular sparing, bitemporal, congruous, homonymous hemianopia. These are the visual pathway, the detailed visual pathway. These are the extraocular muscle involvement. The oculomotor nerve palsies. There may be a third nerve palsies. Third nerve palsy can occur with the basilar compressive optic neuropathy. This is how you ptosis, exotropia, and affect all gazes except the lateral gaze. Fourth nerve palsy can affect the midbrain lesions, intracranial or intracavernous or intraorbital. It's a very slender nerve and the longest nerve which can damage easily with minor head injury. Therefore, it causes double vision, vertical gaze, especially when you are looking down. And the patient may have abnormal head posture because the patient is tilting the head because to correct the double vision. And there may be face turn. Those are the head posture, abnormal head posture to correct double vision. Here, because when the patient turn the head to the affected side, this hypertropia may worsen. Therefore, patient turn the head to the opposite side with chin depression and face turn. This is how you elicit the fourth nerve. The sixth nerve palsy, the abduction is failed, and therefore the eyesight is appropriate, and you can adduct the eye on the affected side when you are moving the eye to the affected gaze. The sixth nerve palsy, the eye signs are very important because though it's not oculomotor nerve, but if it supplies the orbicularis oculi, which causes the lids. The lid movements are usually supplied by the seventh nerve. It's a muscle of the orbicularis oculi. Therefore, if it is not functioning, they can't close the lid and they get exposure keratitis, epiphora. Its causes are Bell's palsy, post-surgical, neoplastic or intracranial tumors or CP angle tumor. You have to just know the pathway of all cranial nerves to locate where the lesion is. These are the myopathies, myasthenia gravis, because it's a neuromuscular junction problem, right? It's an asymmetrical type of ophthalmoplegia, asymmetrical ptosis. It's may vary with the day. There's a fatigue, and you have to come to a conclusion. You can't fit any palsy, any weakness to the extraocular motor nerve. This is the seventh nerve, the hemifacial spasm. This is overstimulation of the seventh nerve. We call it repeated uncontrollable contraction of the facial muscles. This is due to. So you have the suspect of the aberrant vessels just running over the facial nerve at the CP angle. This is one of the pathology, but usually this is common idiopathic. It's common in females, and then you can just reassure the patient, and they have to reduce it by the Botox injections, or there are some drugs as clonazepam, but it's not completely recoverable. But with the injection of Botox to these supplying areas, you can have some relief, and you have to repeat in each and every 3 months. This is internuclear ophthalmology. This is internuclear, the third motor, oculomotor nerve connections. It can affect in the vascular demyelination or brainstem injuries. It's located in the brainstem. Therefore, it appears as a internuclear ophthalmology, the third nerve and the sixth nerve connection, and midbrain from the rostral interstitial nucleus connect with the third nerve and the PPRF. Therefore, this causes adduction weakness with the adduction nystagmus. This is the left internuclear ophthalmoplegia, which called adduction palsy with abduction nystagmus. Just remember the term. There's internuclear ophthalmoplegia, and you are actually you are not as a medical student or medical officer. You are not expected to just answer. Just familiar with the name, right? That's all. Thank you.
Excuse me, madam.
Yeah.
There were about half of my batchmates were in the separate meeting. It was like a waiting room, I think. So they couldn't get logged into this this meeting. So madam, could you please upload the lecture note to the LMS? Lecture presentation to the LMS.
I can give.
And the other thing is, madam, the lecture was not recorded.
You can't record it.
No, madam, we can't record it without madam's
permission.
Yes,
I'll give. Last lecture also I gave. Last lecture also I gave, but you can collect that which I did, and it was in. I can't remember after Darshana. There's a laptop there. I can't just exactly with whom. There was a TO, a technical officer, somebody. I can't remember the name. With his laptop, the lecture is there, right? I'll give this one to
okay, madam.
Somebody just remind me while I'm coming to the ward, then I can hand it over. Okay?
Okay, madam. Thank you very much, madam. And can we have your email address?
I am Lalita Senarath, LALITHA SENARATH NARATH at yahoo.com.
Yahoo.com.
Yeah, or Gmail or anything. Both.
Okay, madam. Thank you very much.
Okay.